Let's start talking about the principles of occlusion and function. You can see 37 questions in this section. Remember, we're still in dental anatomy and occlusion, so this is about a third of that whole section. This section includes the TMJ, it includes muscles, it includes occlusal contacts, and it includes function through those movements. The TMJ itself is mentioned a little bit in your anatomy section, but we're going to hammer it right here because the better you understand it, the more sense these occlusal functional contacts are going to make. So let's jump right into it. Let's start out talking about the articulating surfaces of the TMJ. On the mandible here, we're looking at the head of the condyle. It's got a medial pole and a lateral pole. It is covered in dense avascular connective tissue. This differs from other joints because it's not covered in hyaline cartilage. Let's take a look at the articular fossa of the temporal bone. It's located just anterior to the auditory canal. Remember that medial head of the condyle is going to lie right here against that thick, dense petrous portion of that temporal bone. Posterior and superior to that, it's paper thin, and which could cause big problems if that is allowed to go posteriorly, jamming into the brain. We'll talk about some protective features of that down the road here. The anterior portion of this glenoid fossa is the articular eminence. Once the mandible opens and begins to translate down that eminence, this articular eminence carries the main load, and that's why it's the thickest portion of the bone. Remember, this joint is covered by thick, avascular, fibrous connective tissue, not hyaline cartilage. In between the head of the condyle and the fossa lies a disc. It's biconcave. It's got a thick portion on the anterior, and it's got an even thicker portion on the distal. As the condyle opens and translates, this disc moves with it. We'll talk about some ligaments that help hold it in place and muscles that cause this movement to happen. Let's talk for a minute about imaging the joint. We've got three modalities we can use to image it. You can take an X-ray, like a panoramic radiograph. This does a good job of showing the hard tissue, but it's limited because it only shows it in 2 dimensions and doesn't show the disc very well. You can take a CT scan, which does a great job of showing hard tissue, but again doesn't capture the disc. The gold standard for imaging is the MRI. Let's talk about the ligaments of the TMJ. The disc is held in place by the collateral ligament. It attaches the disc to the head of the condyle like a bucket handle, attaching on the medial and the lateral poles. It allows it to rotate forward and back as the disc moves. It also forms a fluid-filled cavity superior and inferior to the disc. The next ligament is the capsular ligament. The capsular ligament covers and protects and surrounds the temporomandibular joint. It keeps fluid in place and keeps the joint from moving laterally. The temporomandibular ligament attaches from the eminence to the posterior of the neck of the condyle. This ligament initiates translation of the mandible, going from rotation to sliding down that eminence. Also, during trauma, this limits posterior movement of the mandible. Remember, we talked about that thin wall distal to the head of the condyle? If too much force is applied to the mandible, it will actually fracture the neck of the condyle, preventing that from going into the base of the skull. Our next ligament is the sphenomandibular ligament. Remember the lingula, right by where the inferior alveolar nerve enters? This ligament attaches there and then attaches to the sphenoid bone. This is going to limit excess opening of the mandible. Our last ligament is the stylomandibular ligament. It attaches to the styloid process of the mastoid bone into the posterior of the mandible and limits excessive protrusion. The TMJ is innervated by the auriculotemporal branch of the trigeminal nerve. Oftentimes, when patients have TMJ problems, they'll come in and they'll describe a pain that goes up and around behind their ear, following the pathway of that auriculotemporal branch of that trigeminal nerve. Let's take a look at the muscles of mastication. All these muscles are innervated by the trigeminal nerve. Pull up that diagram that's in your book of the muscles of mastication and let's go through them. The masseter is the main chewing muscle. It's the primary elevator along with the temporalis and the medial pterygoid. The temporalis elevates and retrudes the mandible. It coordinates and positions during closing movements. The medial pterygoid muscle attaches from the sphenoid bone to the angle of the mandible. This muscle elevates and protrudes the mandible, and it forms a sling around the angle of the mandible. The lateral pterygoid is your main synchronizing muscle of the condyle and the disc. Make sure you know that this muscle is not an elevator muscle. Remember what the elevator muscles were? They were the masseter, the temporalis, and the medial pterygoid. The lateral pterygoid attaches to the lateral pterygoid plate of that sphenoid bone and attaches to the head of the condyle and the disc, as we've just said. This is the primary mover of the mandible. It's going to shift the mandible forward and left and right. So when we get to movements, this is the main muscle we're talking about. When both lateral pterygoids contract, the mandible protrudes. When only one side contracts, we get translation into a working or non-working movement. One way they like to ask questions about this is they'll talk about an injury to one side of the mandible. Whichever side the injury is on, during protrusion, the mandible will move to the affected side. Let's keep cruising through these last few muscles, and we'll get on to movements. Let's look at the suprahyoid muscles. All these muscles work together to depress the mandible. The mylohyoid forms the floor of the mouth. Remember back from our tooth morphology that the apices of the mandibular molars lie below this mylohyoid line. The infrahyoid muscles are attached to the hyoid or thyroid and work to pull it down. They are active during speaking and swallowing. Let's finish by covering these muscles of the tongue. There may be one question over all of these. If there is a question, the name is going to tell you what the muscle does. The genioglossus muscle goes from the geniotubercle, the anterior of the mandible, and connects to the tongue. So it's in front of the tongue, so it's going to protrude the tongue. The hyoglossus muscle, hyoid bone, is below the tongue, so it's going to depress the tongue. Styloglossus, styloid process is posterior to the tongue, so it's going to retrude the tongue. The palatoglossus, the palate's above the tongue, so it's going to elevate the tongue. All the names tell you everything you need to know. The intrinsic muscles of the tongue change the shape of the tongue. That's really all you need to know about the tongue muscles. Take a look in your book. You'll see several positions listed here. We're going to be applying these to Posselt's envelope. That's where all the questions come from, is applications of these positions. So make sure you know, read through right now, make sure you know centric relation, MIP, rest position, and the neutral zone. Make sure you know what those are, and then we're going to meet back at Posselt's envelope, and we're going to apply those to where the real questions come in. Taking a look at Posselt's envelope there from several different planes, I'm going to point out some of these positions and describe how they function and work together. Take a look at the sagittal plane. Look at the diagram on the left. Remember that MIP has the smallest VDO, is the most fully closed position. So the diagram on the left, it's 0.2. Diagram on the right, where CR and MIP coincide, it's 0.1 and 2. Staying in the sagittal plane, from that point forward, VDO opens as you guide down the canine, across the incisal edge, back up into crossover, and then further into protrusive. If we look at that same movement in the frontal plane, point 1 is still our MIP position, again, which hopefully coincides with CR. As we move across the canine, into crossover, and past it, we form a nice smooth arc going from a fully closed position to a more open position. Make sure and note that any time you move out of maximum intercuspal position, the VDO must increase. All of these diagrams represent border movements. In the sagittal plane, This diagram represents the maximum extent of movement. Notice in the diagram on the left that if you're at maximum opening and you close, you don't close into full protrusive. You close back into MIP, which is represented by the line going from approximately 0.7 to 0.2. You will see that on the test. Don't be confused by saying it's that closing motion into protrusive. We always close into MIP. Remember the neutral zone that you just read about. The neutral zone is established by contracted muscle length. Remember, it's that facial muscles pushing the teeth in, the tongue pushing it out. It's also the contracted length of the masseter. If something violates the neutral zone, where you've opened the vertical dimension, either by a restoration or by an appliance you've put in there, those muscles will return to their contracted length. You can remember this by saying, if teeth and muscle war, muscle will always win. They will always push the teeth back to where they're in balance between the muscles. Another position that we see repeatedly on the exam is swallowing. This is going to be represented by point 1 on your facial plane, points 2, or MIP, on your sagittal plane. So go ahead and try this. Go ahead and swallow for me. When you swallow, feel your teeth clench together. Feel your elevator muscles engage. Remember what those are? Your masseter, your temporalis, your medial pterygoid. You feel your tongue press against the roof of your mouth. Make sure and know those things. You're going to see that on the test. Take a look at all 3 planes. On each one, you'll see a smaller figure within that represents the chewing stroke. When you're chewing, you're not going to the full extent of your range of motion. It's confined within a small motion. On either of these 3 planes, expect to be able to identify the chewing stroke from a lineup of these diagrams. Let's take a look at the horizontal plane to describe the right lateral movement. When a right lateral movement occurs, the right condyle remains stationary and rotates. Remember what muscle affects this move? You're right. The left lateral pterygoid contracts, pulling on the condyle disc assembly, forcing the left condyle to move anteriorly, translating down the articular eminence. For a left lateral movement, the opposite is true. The right lateral pterygoid contracts, acting on that right condyle disc assembly. Remember, during a working side movement, the working side condyle always stays put and rotates. And it is the lateral pterygoid that's active to make the opposite side translate. One way we see them repeatedly ask questions about this is related to trauma of the jaw. If there is an injury to the right side of the condyle disc assembly, which way will the mandible rotate? That's right, the affected side. Remember, during trauma, the jaw will always move to the affected side. If a single pterygoid contracts, we get a lateral movement. If they both contract in unison, protrusion happens. During protrusion, both condyles are translating down the articular eminence. In a minute, we're going to relate these to teeth, and there's going to be a lot of questions that come from these movements and what effect they have on cusps and fossas in the teeth and where they go. The last movement I want to point out is the Bennett movement. This is an immediate lateral bodily shift of the mandible. Remember on your articulators, this is the setting they told you not to touch, just to leave alone. The Bennett shift is small and it occurs right at the beginning of lateral translation. The final point I want to bring up here before we get into our section on occlusal contacts and get into tooth relationships is to point out that the mandible is a class 3 lever, with the fulcrum being the TMJ, the force being the muscles, and the load is always being in front where you're chewing. Remember that because of this, the joint is always loaded and there is never a separating force on the joint.